Hi everyone. Hello everyone. Good afternoon, and welcome to the first physiotherapeutic scoliosis specific exercise Schroth pre-webinar meeting. This is the first, and we are holding this meeting with approximately 750 registered participants. And also, let me say, interestingly, today also 8 April, is National Physiotherapist Day in Turkey. And so happy day for all physiotherapists. And we will start with part 1. After that, in part 2, and lastly, we will finish part 3 and without any break. Please write your questions to just the bottom questions and answers or Q&A section. And the moderator will ask your question to the presenter. Now let's start, and in part 1, we will start with Lukasz Stolinski from Poland. He will give a presentation on clinical evaluation. Here you are, Lukasz.
Thank you, Yavuz. Hello, everyone. I will try to share my screen now. Yavuz, can you check it's everything okay? Okay.
Okay, it's okay.
Thank you. Ladies and gentlemen, dear attendants, dear friends, it's a honor to be with all of you today. I would like to show you basic information about clinical assessment for scoliosis screening. General clinical evaluation of posture, including quantitative assessment of shoulders, scapulas, waist and chest, lumbar prominence, pelvis, mobility of thoracic spine, and additionally, quantitative assessment of angle trunk rotation at ATR, sagittal curvatures of the spine, and photographic parameters in frontal and sagittal plane. During clinical evaluation, we need to look for undressed child in different, mainly standing positions. It means from front, from back, and both sides. Helpful can be hair pin-up to see upper part of the body. During assessment shoulders in horizontal plane, we need to special look for different levels of them because scoliosis patient has one of shoulder mainly set higher. It is because one of the shoulder, mainly right, is positioning in protraction during scoliosis progression, and we can say it's preparing the space for opening ribs on the right side. It's developed rib hump during growth. In patient with large scoliosis, asymmetry and protraction of shoulder is simple to observe in each of plane. Asymmetry of the shoulders depend on scapula position, which is natural in frontal, sagittal, and transversal plane, pushed by the rib hump from thoracic region. In scoliosis patient, we should to look for a waist which is asymmetrical. One of them is deeper and located in a different level. Waist angled both sides and difference are right-left distance ratio are different too. Looking for waist, we should to zooming our attention for ribs positioning because there is an asymmetry too, which is associated with trunk and spine rotation. Lumbar prominence is quite important for diagnosis because it's mostly appearing in the lumbar spine as a compensation of thoracic scoliosis, developed opposite direction lumbar scoliosis. Interesting is when we are assessing for a scoliosis patient, we can observe a pelvis without asymmetry in frontal plane, but curvatures of the spine are unnatural, and especially sacral slope, lumbar lordosis, and thoracic kyphosis are under normative data in our measurement process. During movement of the spine for deflection, we can observe a natural mobility, especially in lumbothoracic junction and thoracic region. We can see lower mobility of the spine. For the purpose of early detection of idiopathic scoliosis, it is recommended to assess the asymmetry of the back performed by means of Adam test on bending the trunk forward, the measurement of the trunk rotation angle. I would like to show you today assessment with the use of scoliometer, banner scoliometer, which is most popular tool for scoliosis screening. For the objective measurement of the trunk rotation angle, the use of the scoliometer is recommended for scoliosis screening. Starting position of the subject in standing position with feet placed parallel on to another in one line, hip width apart, knees joints straightened. Bending the trunk is going forward, upper extremity hanging freely or with palm side of the hand connected. On these slides, you can see rib hump and lumbar prominence in scoliosis patient during forward bending. For much more understanding, I try to show you a trunk of scoliosis patient from front and from back of the body during bending with compilation of the photos which were done based with standardization from digital photography technique. On these movies, I tried to show you this forward bending of the body done by some patients. Together with Professor Dariusz Czaprowski from Poland and his leadership as a team from Polish Science Academy, we were able to create recommendations for scoliosis screening. These indications are presented in our country and in some international conferences and some scientific papers after a long time of discussion and scientific analysis. It is recommended that the measurement of the trunk rotation angle be performed at the level of all spinous process, noting the maximum value in the proximal thoracic, main thoracic, and thoracolumbar or lumbar part. It is recommended that while measuring the trunk rotation angle, the range of forward bend be regulated by the examiner in a such way that the assessed region of the spine is parallel to the floor. In the case of lower limbs length differences or the lack of possibility to perform the test in standing position, the measurement of the trunk rotation angle can be performed in the sitting position too. For assessing of scoliosis patient sagittal curvatures of the spine, we can use, for example, a Sanders digital inclinometer. This reliable measuring equipment is really helpful for quantitative assessment of the spine region. We can also use our smartphones for assessing sagittal curvatures in special applications which can be downloaded from the internet. Because of lack of time, I would like to present only some simple photos which can imagine a measuring process. Recommended for documentation and quantitative assessment of the body for scoliosis patient can be digital photography technique. ATSI, anterior trunk symmetry index, is assessing the front profile of the patient trunk. The parameter is defined as the sum of 6 indices, 3 frontal plane asymmetry indices, it is sternal notch, axilla folds, and waistlines, and 3 frontal plane height differences indices, it's mean acromions, axilla fold 2, and waistlines. POTSI, posterior trunk symmetry index, is assessing the back profile of the patient trunk. Similar, the parameter is defined as the sum of 6 indices, 3 frontal plane asymmetry indices with C7, axilla folds and waistlines, and 3 frontal plane height difference indices, acromions, axilla folds, and waistlines. Documentation using digital photography for sagittal curvatures of the spine in scoliosis patient should including photos done from both sides, right and left. Because of asymmetries of the trunk, we need to sign some additional points on the body before photographic process, which can help us to assess these regions from side views. On the photos, we can calculate sagittal parameters. In the absence of specific measurement equipment, we can do this on the photos. Without costs, we can obtain reliable using photos which were done during patient visit in our treatment office. Further, we can also calculate some important photographic parameters and verify effectiveness of our method. In cooperation with Dr. Pavel Czerny from Czech Republic, parameters calculating process can be much more simple now. In automatic way, we can calculate ATSI, POTSI using this software on the computer. Sagittal curvatures of the spine are possible to measure too when we are using Scoliac software, which is free for the use and download from the internet. During last years, with cooperation with Dr. Czerny, application for smartphones with Android system could have been created. As in a computer software, application for smartphones let us calculate photographic and radiological parameters too. So this is the next step for more simply measurements using our phones, which are present almost in every human hands. For download this free application, we should only visit Play Store. Thank you for your time and for your attention. I hope it will be very helpful to diagnosis and in scoliosis patients. Thank you very much.
Thank you, Lukasz. Thank you very much. I will get questions at the end of this part. I mean, after three presenters. Thank you very much. And now, secondly, Larisa Iacob will give a presentation on radiological evaluation. Here you are, Larisa, welcome.
Hello, thank you, Yavuz. Please tell me if it's okay with my screening. Okay, you can see my...
Yes, we can see it.
Okay, perfect. Good afternoon, everyone. It's a pleasure to be here with you and share my presentation with all of you. Today, we will speak about radiologic evaluation of the patient with scoliosis. X-ray are still the most reliable method for assessing and measuring a spinal curve. The most important measurements on X-ray are these: angle cob, vertebra rotation, Risser sign, transitional point, and Sanders scale maturity. All these measurements are very important to determine the prognostic of the scoliosis. So I will start with the first one, which is cob angle. I think everyone who works with scoliosis must know what it represents and how we can measure it. The angle cob is defined as the angle between upper end vertebra and lower end vertebra of the curve. For measuring the cob angle, we draw two parallel lines on upper end vertebra and lower end vertebra, and after we draw two perpendicular lines from them, and we measure the angle between these two lines. We have also other way to measure the angle cob. This is SurgiMap, which is a free download application, and some smartphone application. For measuring the cob angle, okay. Now we will speak about vertebra rotation. Here we use Nash and Moe method and also Raimondi method. Nash and Moe method. The half body vertebra of the convex side of curve is divided in three segments. The rotation is quantified on the basis of the percentage displacement of the convex pedicle in rapport with vertebral body. The rotation is classified in 5 different degrees according to the removal of the pedicles. In Raimondi method, first, we have to measure the weight of the vertebral body. Then we measure the distance between the middle of the pedicle and the edge of the vertebra, both of them from the convex side. These two values are shared in the roller, and after we will have the rotation, the vertebra rotation. Now we will speak about Risser sign, measurement that assists skeletal maturity of the patient. Risser sign represents the stage of ossification of the iliac crest apophyse. The graders are as follow. Risser 0, which means no ossification on iliac crest apophyse. Here we have Risser 0 minus when the triladiate cartilage is open, and Risser 0 plus when triladiate cartilage is closed. After we have Risser 0 with approximately 1/3 ossification of iliac crest, Risser 2 with approximately 1/3, 2/3 ossification of iliac crest apophyse, Risser 3 with 2/3 ossification of the iliac crest apophyse, Risser 4 with approximately 100% ossification, and in Risser 5 we have complete ossification and fusion of iliac crest. The next measurement is transitional point, which represents the middle point between the lower end vertebra of the thoracic curve and the upper end vertebra of the lumbar or thoracolumbar curves. It highlights the frontal plane imbalance. When we speak about radiologic evaluation, we also must speak about Sanders maturity scale. The Sanders maturity scale is based on a left-hand X-ray, and it's considered one of the most one of the best predictor of the curve acceleration phase of the growth. In the end of the presentation, I want to share with you some results from, with the patient who was treated with PSSE-Schroth technique, a unique method that was recently introduced by Nikos Karavidas. Here we have patient. Oh, sorry. Okay. You can see in this example the correlation between the improvement in clinical picture and also in X-ray. Here we have a better body asymmetry in frontal plane, and also the position of the transitional point, it's more close to the central sacral line. We see also weak point and weak side, which are not so collapsed in relation with the Cobb angle, which is reduced. The trunk rotation is compatible with vertebral rotation, both being improvement. I want to mention that this case, the difference between this case is that the first one, it's treated only with Schroth exercise, and the other one, it's treated with Schroth exercise and also with brace. Okay. Here, and here you can see also improvement in clinical picture, Cobb angle, vertebral rotation, transitional point. Thank you for your attention, and I really hope that you enjoy my presentation.
Thank you, Larisa. Thank you very much. Now, the third one will be presented by Merve Karatel and early detection and prognosis. Here you are, Merve.
Thank you. Can you see my screen?
Larisa, could you close your...
Oh, sorry.
No, not important.
Now you can see my screen. Thank you. Hello, everyone. My name is Merve Karatel. I'm from Turkey. Today, my topics are early detection, school screening, and prognosis. Due to the asymptomatic nature of scoliosis, sometimes it may be overlooked. Early diagnosis can prevent progression as well as help to benefit more from conservative interventions. In the detection of scoliosis, school screening is an early, easy, and cost-effective solution. Several different diagnostic tools are available. For example, Adams forward bending test, Adams test with scoliometer, topography. Each has varying degrees of sensitivity and specificity. This research is about school-based assessment protocol for early diagnosis. They presented the very high specificity of the combination of Adams test, axial trunk rotation, and plumb line, and which are the most commonly used in the clinical practice. Adams test is still considered the best non-invasive clinical test for screening scoliosis. We are running school screening projects in southeast of Turkey with Professor Yakut. Easy and practically applied method that we use in the school screening is forward bending test and scoliometer for assessing axial trunk rotation. When we read greater than 5 to 7 degrees on the scoliometer, we usually refer to a specialist. There are some smartphone applications that act as a scoliometer. This paper is about the comparison of healthcare professionals and parents in the screening for adolescent idiopathic scoliosis. The sensitivity of screening was lower when it was performed by parents. For this reason, it's important screenings that are responsible for health professionals. We know that idiopathic scoliosis has progression risk, especially during the growth spurt at puberty. Positive family history, age of menarche for girls, curve type, curve magnitude, laxity, flat back, hypokyphosis, angle of trunk or vertebral rotation, growth spurts are some high risk, potential risk for scoliosis progression. Launcton and Carson offered a factor for assessing progression risk. This is formula for calculating the progression factor. For example, 10 years a girl, premenarche, RISAR 0, Cobb angle 24 degrees. Progression factor is from this formula 2.4. 2.4 is 90% progression risk. The other side, 14 years old, RISAR 3, same Cobb angle, a case. Again, from this formula, progression factor is 1.1. 1.1 is, from this graph, approximately 25% progression risk. Same Cobb angle, different progression risk, and definitely different intervention plan needed. Sorry. Sometimes spontaneous improvement can occur in scoliosis, but sometimes rapid progression is happen, especially during the peak of growth. This curvature became this after 50 days later, not even 2 months. Vicious cycle theory can explain vertebral body wedging during growth results from asymmetric loading. Therefore, evaluation of prognostic factor is really significant for us in clinically. These are my references. Thank you for your attention.
Thank you very much. Now we are just on time, no any delay. So let me direct the questions to you. We have now 3 different questions. Firstly, Lukasz, could you tell us, and there is a question that, what is reliability of spinal mouse tool for scoliosis? What do you think about that?
Triton Tifeku, thank you very much for the question. I think the question is interesting, but in my opinion, not for me, because I'm not using a spinal mouse. But the first clinical results can be interesting. In my opinion, the most difficult thing in this way is that price of the spinal mouse. So when we need to use it in our practice, everyday practice, we need something simple and cheap, like photography, even like a scoliometer, inclinometer or some smartphone application for smartphones. But these equipment, which are expensive, I think they are checked for the reliability. But in my opinion, it's is too small for this, I think.
Okay, thank you. And also, can I say something about this? For scoliosis, reliability test, retest, and intertest, the reliability of the mouse, I think, is low. There is only one presentation in my country, but I think test, retest method not so good. But in kyphosis is okay, especially for school screening, it's okay, but for scoliosis, keeping mouse on through areas not so easy, and I think it's not so good for test reliability, especially for scoliosis. Thank you. And the other question for Larisa, what do you think about that COP method advantage and disadvantage of COP method? What do you think about that?
Thank you for the question. I think the advantage is to have the exactly measurement of scoliosis angle. And for disadvantage, we know that in COB angle, we can have errors from 1 to 5 degree. And it means that it can be subjective.
Okay.
Sorry, and also the advantage of the X-ray of the clinical of the radiologic evaluation is that we can show the evolution of the patient.
Okay, thank you. And the other questions direct to Merve, but I can answer these questions. What about torticollis and correlation between torticollis and scoliosis? And there is no directly any correlation between torticollis and the starting of scoliosis, but for congenital some problems, starting with cervical scoliosis plus torticollis, and then secondary thoracal scoliosis is possible. I treated only one baby for this situation, but I don't read any article, or there is a lack of articles or research on correlation between torticollis and scoliosis. Okay, there is also one question. What about Lukasz? What do you think about I think this is the last question. What about Lukasz accuracy of kyphosis method, measurement of kyphosis? What do you think about that?
If I could understand from Isis, thank you very much. The question, Isis. I think we do similar things with Isis. yes, the accuracy should be very careful because the most important in measurement of kyphosis or lordosis on our sagittal spinal curvatures is accuracy. It's a standardization. So if the measurement will be done with standardized procedure, it can be very good accuracy for the measurements. In our previous papers about photography or inclinometers with Dariusz Czaprowski and Tomasz Kotwicki, we tried to show the reliability, intra-observer and reliability, inter-observer reliability, and the results were quite good for measurements with the use of inclinometer or Ripstein plurimeter, photography. So I think the main and good information, good answer for the question is in our previous papers, I think.
Okay, thank you. We are happy also that about participants, maybe 10 different countries: England, Romania, Greece, Turkey, Albania, Egypt, Germany, Kenya, and blah, blah, it's Poland. And we are very happy. Now I am finishing part one. Now we will start.
I think, Yavuz, I think that we are quite good on time. So we still have 4 minutes of discussion. So please feel free if you have any live question. I have seen some hands to be raised. So I can allow you to ask your questions if you want.
Okay. Okay. Any questions? Oh, Stella, here you are. Stella, could you open your video also? It's possible. And also Iran. Yeah, hello. Stella, can you hear me? I think there is a sound problem. You can write, or now let me direct to Driton. Driton, you can ask your question.
Hello, can you hear me?
Hello. Yeah.
Yeah. Congratulations for the webinar and for the opportunity. I want to thank Nikos and Silvio. He's my friend, my brother from Albania. Actually, I did too much question for each presenter. I don't know if I was too much clear. My question for Lukasz was if it's what is the reliability of spinal mouse. I don't mean as a cheap or expensive, but I mean in terms for diagnostic tool for scoliosis, it's helpful or not? Because as Yavuz explained it, it's good to, for example, to do the assessment of kyphosis, but not scoliosis. I want that kind of thing. If it's good, because as we know, we have curvature in 3 dimension. That's why I think it's not too much useful, but some of the guys here use as a diagnostic. That's why I want to know from it.
Yeah. And let me say again, Driton, test-retest reliability between users, I mean inter-tester reliability is very low. But within tester reliability, maybe 0.8. It means that you cannot use in clinical usage because for clinical usage, you need 0.9 agreement, ICC agreement for practical clinical uses. And also you need someone needs to education on holding spinal mouse correctly, especially for three-dimensional. If you lose or if you forget the turn, or I mean, you are directly measures spinous processus. It means that not directly vertebra, just spinous processus. It means that for spinous processus, if turns, you can calculate, or you may measure it lower than real decrease. This is the main problem. But for kyphosis, you are measuring only one direction or one plane in sagittal plane. If you hold directly your mouse very well or holding straightly, no problem. But for scoliosis, I don't think so. I use it also. But instead of it, Adam test is better than for me. For my
It's
opinion.
okay.
Thank you.
Thank you very much for your questions. And now we're moving forward to the part number 2 of our agenda. And the next presentation will be by Georgiana Cojocaru from Romania. And the lecture will be about the physiotherapeutic scoliosis specific exercises, guidelines, and evidence.
Thank you, Nikos. Hello to everyone. I'm happy to be with you here. Now I will start to share my presentation. It's okay?
Yes, it's okay, Georgiana.
Okay.
You just share a slideshow from the beginning.
Okay. Now let's have a look on guidelines and scientific evidence for physiotherapeutic scoliosis specific exercises. Nowadays, we have high quality evidence for physiotherapeutic specific scoliosis exercises. We have systematic review with meta-analysis, randomized control trials, both of them are level 1 of evidence, prospective studies, which are level 2 of evidence. In my next slides, I will emphasize the most important studies which present the effectiveness of scoliosis specific exercises in scoliosis treatment. Here we have a good evidence from Monticoni and his colleagues from 2014, a randomized control trial that show us PSSE improved Cobb angle, trunk rotation, quality of life at a long-term follow-up. In this study, they had 2 groups, one with PSSE and second one with general exercises. And the conclusion was that PSSE have better results than general exercises. Here we have another randomized control trial from Turkey, from Kuru and his colleagues. They used 3 different groups. First group, supervised Schroth, second, home Schroth, and the third, observation. They had 6 months follow-up and they found that only Schroth supervised group has significant improvement in Cobb angle, in trunk rotation, reduced ham height, and weight asymmetry. When in control group was no improvement in any parameter. So they conclude that Schroth method seems to be effective in scoliosis treatment, better than observation. Another randomized control trial, this time from Canada, by Schreiber and colleagues, that show us Schroth method added to standard of care observation or brace for scoliosis can reduce the Cobb angle and the severity of the curve. Here we have a prospective study from our instructor, Nikos Karavidas, from 2022, which show us that the combination of brace and PSSE exercises can effectively treat adolescent idiopathic scoliosis at the riskiest period during a peak of growth. And the last one is a systematic review with a meta-analysis from last year, which concluded that PSSE can reduce spinal deformity and improve quality of life as isolated treatment for mild curves or combined with bracing in moderate curves. Here we have the social guidelines, which recognize that PSSE are the first step in treat scoliosis and prevent progression or bracing. PSSE are based on 3D autocorrections, activity of daily living training, and stabilization of corrected posture. PSSE programs are designed only by certified physiotherapists. The program is individualized according to curve type, patient's need, and treatment phase. To achieve the best results, it is recommended to have a multi-professional therapeutic team made of doctor, orthotist, and physical therapist. Brace treatment should be accompanied by PSSE, and patients are encouraged to participate in sport to their general benefits, but sport activities cannot be considered as alternative treatment. Now, let's take a look what international scientific societies think about scoliosis-specific exercises. This is official scoliosis research statement on physiotherapy scoliosis-specific exercise from May 2014, and then they admit that a combination of brace and PSSE seems to provide better results in scoliosis treatment. There is scientific evidence that PSSE are superior to general or no exercises. Another position statement is coming from American Association of Orthopedic Surgeons, Scoliosis Research Society, Pediatric Orthopedic Society of North America, and American Academy of Pediatrics, which believe that scoliosis-specific exercises can decrease the likelihood of curve progression. The most powerful scientific society, SRS, has in their agenda research about non-operative treatment of adolescent idiopathic scoliosis. Here, the Society of Europe, Eurospine, has already started a diploma for every professional in interprofessional spine care. Now let's talk about this term of PSSE, which was introduced to differentiate between what is really specific and non-specific for scoliosis treatment. According to Schroth, the methods which use this term, PSSE, should be curve pattern exercise and should have some common basic characteristics. To teach patients autocorrections in 3D, to make sure they understand how scoliosis is affecting their posture and train them in activity daily living, and how to stabilize the corrected posture. These are the schools that use the same general principle. We have scientific exercise approach to scoliosis from Italy, Lyon from France, PSSE-Schroth and Schroth best practice from Germany, Barcelona Scoliosis Physical Therapy School RICO concept from Spain, Dopomed and Functional Individual Therapy of Scoliosis from Poland, SideShift from England, and our new method recently introduced by Nikos Karavidas from Greece, PSSE-Schroth. Now let's have a look on treatment indications recommended by Schroth guidelines in 2011. We can work with PSSE with mild scoliosis, usually with Cobb angle between 15 to 25 degrees, at the research stage 0 to 3, Cobb angle between 20 to 40 degrees at research stage 4 to 5, with braced patients, no matter how big curves are, and with adults with any Cobb angle and pain. On the right side, you can see the recommendation from our method, which include also patients with Cobb angle less than 10 degrees. But if they have a positive Adam test, and we can see on X-ray vertebral rotation or deformity, it shows us it can have progression. So it can be a hidden structural scoliosis. And our recommendation is to work also with adults, no matter of Cobb angle, with or without pain, aesthetic issues, they can benefit from this treatment. Thank you for your kind attention. Now I will stop.
Thank you, Georgiana. You just have to stop sharing your screen, and the next presenter will be Professor Yavuz Yakut, speaking about bracing for scoliosis. Just before giving the word to Professor Yavuz Yakut, I would like to mention again that you can feel free to text your questions to our panelists on the Q&A section that you can find on the bottom of the toolbar on your Zoom screen. We prefer to do it that way for the questions so that we allow more time for answers. But if we have some free time at the end of the discussion, maybe we can allow also some live questions. So Professor Yavuz, you go forward with your presentation.
Okay, thank you, Nikos. And hello again, everyone. Now, my main subject also orthosis, I mean spinal orthosis, especially for scoliosis, and about maybe 40 years, 35 years, maybe. But in 1919, was not so good years because before then, orthosis has not enough evidence-based research. But I think it's a milestone by Athens, and then the biomechanics of spine, he worked very well, and he said that brace works. So it means that after then, especially starting of evidence-based medicine and evidence-based practice, we can see that orthosis for scoliosis is useful and beneficial. So that's why there are some research or evidence that demonstrate effect of scoliosis braces. Now, there are too many scoliotic braces, especially I think milestone is Milwaukee, before Milwaukee, after Milwaukee, and Cojocaru style orthosis, and the other orthosis will be spread, especially Boston. And firstly, let me say something about chain orthosis. Two main part of it, and the passive and active correction system. And this system especially affected by Schroth method, directly Schroth method. So principles of orthosis originate from Schroth method also. The other one, Rigo system channel brace, and scoliologic channel light from Germany. Rigo system from, as you know, Barcelona, 3-point channel system, and the Boston orthosis. Initially, it was very popular, especially derotation and antilordotic effect, and then very flexible spine core orthosis, but research are not so good. Leon orthosis, Sforzesco, and the collaboration of Leon and Sforzesco is new one, sport art orthosis, especially for very hard or very, very rigid orthosis, and you can see other orthosis. Let me say something about Providence orthosis, especially for nighttime orthosis, especially initial or starting of orthosis, and the 10 hours per day will be beneficial at the starting, and flexible or scoliosis. As I said, the Milwaukee orthosis, as you know, 3-point system, active traction, but most problem is compliance, and also in some cases, delirium or neurotic reactions will record it also. This my orthosis type is especially for low degree scoliosis. Now you can see some correction principles of brace. It differs from level of scoliosis because in lumbar curves, as you know, this method, and the pressure will be firstly rotation, then lordosis and scoliosis. But in thoracal area, it differs, especially for rotation and frontal or coronal pressure differs. And also very important thing of three-point system, level of a distance between F3 and F1 and F2. So if F1 and the F3 distance decrease, pressure will be increased. You have to notice this is the basic curve pressure system, especially for scoliosis. In sagittal plane, kyphosis and lordosis will be controlled or will be checked, especially for correcting lordosis is not so good. For manufacture, I use 4D Rodin and especially classical plaster bandage method. It depends on the patient's situation, of course. In my opinion, for control of orthosis or checking of orthosis, firstly, 10 days after the orthosis is started, and then control of localization of pressure, especially its true place or also low or high pressure, checking for low and high pressure. And the other situation is follow-up. I prefer 3 months following period, especially rapid growth period. And I decreased its distance 2 months, especially September. I mean, end of summertime is very important for checking orthosis because rapidly grow starts in general, of course, at the end of summertime. So all September time, I will call my patients just control orthosis. Now, let me show some samples. Let's say control of localization of pressure is wrong because just lateral pressure, but rotation not so good. So these patients, I added some rotational pressure. This is also best way for control of the orthosis by X-ray with orthosis, if it's possible. Now, upper border and lower border of orthosis, but checking the materials, pressure area control, and checking the inequality of extremities with an orthosis is very important. The important thing is, especially for thoracal curve, we are pressing or we are pushing the costa, so we will follow costal direction. It means for rotation and for lateral banding pressure are not in same level. It will be difference. For lateral lower, for rotation, it must be up level. And let me say about orthotic failure, 7 risk factors, especially 3 of first are very important. Inadequate compliance, compliance is the basic for that. And no skeletal growth and over 40 or 50 degrees. The other depends on the low studies. But correction with a brace, especially low initial correction, low reserve sign, and young age is a high risk for bracing failure. Now I prefer 6 main exercise system at the scoliosis specific exercise. Starting orthosis exercise, reducing side effect, embrace, prevention of compensation, especially cervical area, weaning process, and back pain. According to current evidence for brace, 2 randomized controlled trials, of course, still there are lack of some evidence, but it means scoliosis, for scoliosis, especially for orthosis, team work focusing of adherence to treatment, acceptability, family and patient involvement. Thank you very much.
Thank you, Yavuz, for this presentation. And now let's see some of the questions. So one question is for you, Yavuz, based on your experience or in your opinion, which brace is the best one, or it depends on the type of scoliosis or cob angle. So what do you think?
Okay, perfect questions. Let me say about something. Especially for rigid and high level, high decrease scoliosis, I prefer Cheno style and maybe also aggressive orthosis. But lower decrease and flexible scoliosis, I prefer more symmetrical orthosis. Not so aggressive, not so asymmetrical. Especially I will decide also what about the double major or compensatory curves. For compensatory curves, I use always at that area symmetrical support and aggressive for primary curves. It depends on the patients.
Okay, now let's take a look.
Let me say about something about, especially for compliance at the starting and nighttime or daytime, which patients prefer, and the half day using will be beneficial for starting, I mean for compliance. Suddenly you cannot suggest the patient using 20 hours, directly 20 hours. It's very hard to use. So I think the nighttime orthosis will be beneficial with the starting.
Okay, as far as we started with brace, let's go forward with the bracing questions. So there is a question by Leyla Yildiz from Turkey. She's an orthotist, and she's asking about overcorrection that you can see sometimes when you make a brace for the patient, and if you have experienced, Yavuz, this situation, and what is your opinion on that, or how to manage any tips and tricks?
For overcorrection, that's why I said that for overcorrection, I use not overcorrection. Instead of it, I will check, or I check if second or double curve. If second curve or compensatory curve, I prefer symmetrical at that area, but collaborate with physiotherapist also, not only just making an orthosis. I am also physiotherapist, but this is a very important collaboration with physiotherapist and orthotist about orthosis. Let's say primary curve is lumbar side. I prefer some of my patients symmetrical thoracal support, not aggressive. It also aggravates secondary curves to double major. So not so aggressive, keep symmetrical.
Thank you for this answer. If I'm allowed to add my experience also on that, based on the way that now we treat our patients with PSSE-Schroth method, I think that overcorrection is dependent on the care type that you treat. So the idea, as you will see later in my personal presentation, behind the PSSE-Schroth method is to get the maximum of correction when this is allowed. and to avoid compensations when this is risky. So I think that maybe in the near future, we would be able as a group of a multidisciplinary team to maybe use these clinical classifications, the clinical classification of PSSE-Schroth method, also for brace design. And I think that is important to have a good collaboration with orthotist and physiotherapist. And we have a last question for Yavuz.
I saw a question, isn't it?
Yeah.
What do you think about the changing? Yeah, I think thumb is, let me show my thumb. It equals approximately diameters of a costa. It means that if a patient's head up 3.5, I mean 1 inch, we need to change or adapt the orthosis. But after 4 centimeters, we have to change orthosis because affect areas changes, especially for upper level. Your pressure area changes and you can aggravate the curves. So I mean 3 centimeters, 4 centimeters is up limit for growing.
Yeah, so this is again typical when you treat a patient that you do brace modifications, but from some point on is not easy to modify. But please, for everyone, take care. It is related not to the actual standing growth, but also to the, but mainly to the trunk growth. So this is why, one of the measurements that you can do is sitting height of the patient, so that you can estimate as an orthotist what is the actual growth of the trunk, because the brace is fitted on the trunk. So sometimes you might need to take a look also on that. Okay, for the questions that we have no time to be answered live, the panelists will give you the answer later on. So let's go forward with questions for Georgiana. So there is a question about sports and scoliosis, very typical question also from my experience. Usually the families, the patients, they ask you what is the best to do or what to avoid. What is your insight on that, Georgiana? And also the same participant asked about swimming and scoliosis, and is not really a recommendation as a treatment, but what about as a leisure time activity, and what are the reasons for not being it considered as a recommendation? So, Georgiana.
Yes, thank you for that question, Andrei Bobicianu. So the studies show us that the scoliosis patients don't have any contraindications in any sport. So they shouldn't have this fear of doing sport. But what is really important is to have a good treatment and brace if it's indication for the brace. They shouldn't replace the treatment with sport activity. Yeah, and about swimming, let me check the question.
The question about swimming is, I just clicked this to be in the answered questions. So is if when you can think that swimming could be considered as a recommendation, or what is the reason for not recommending swimming?
Yes, swimming, it can be as a recommendation, because usually the doctor said to the parents to do swimming, but the parents think that they can replace the treatment with swimming. I mean, they can benefit from any kind of sport. It doesn't matter if it's handball, if it's tennis, swimming, but shouldn't replace the treatment with swimming.
And I have to add on that there is a very recent publication by the ISICO group from Italy, from Alessandra Negrini, Stefano Negrini, Michele Romano, and the ISICO team, About sports participation and scoliosis, it was published just like last month, I think. The results are quite interesting, that more participation in sports can prevent in some way scoliosis progression when it is accompanied by exercises. It will be nice to discuss about this in the future with the ASICO team. Okay, I think that for the remaining of the questions, the panelists, you can give the answers by texting to the participants, and we can move forward to the last part of our webinar.
Okay, thank you, Nikos. So we can start the third part of our webinar. Please, Nikos and Burcin, to present PSSE-Schroth classification, and we hope it will be very good information for us. Please, the stage is yours.
Thank you, Lukasz. I will try to share my screen. Can you see it?
Yes, we can see the screen.
I'm sorry for the late. I have some problem with my screen.
Okay, we can try to go down with your mouse for the presentation to the icon to down to put.
Where is the slides share?
Down, down, down. Okay.
No.
Go on the left. Go on the left. On the left. On the left. Left.
Yeah.
One.
I'm sorry. Thank
That's
you.
it.
Okay.
Hopefully my Turkish are working quite well.
Yes,
so far.
yes, very
All
well.
right.
Your Turkish is very well.
Go forward, Burcin.
Hi everyone, I am Burcin Serinturk from Turkey. I am happy to be here with you. I will be guiding you how can we classify scoliosis according to PSSE-Schroth, and the content will be covering the types of scoliosis and approach we should have in Schroth method. Yes, let's start with the classifications. We have in our classification also kyphosis. Kyphosis can be on thoracic region, thoracolumbar region, or lumbar region. We call them KT, KTL, or KL according to region. K type stands for kyphosis. Moving into scoliosis, we have 4 main types of scoliosis. The first type is 3C. 3C means structural thoracic scoliosis and pelvis shifted to thoracic concavity. And the next type, 4C type. 4C means structural thoracic scoliosis and pelvis shifted to thoracic convexity. And the next type, non-3, non-4 type, means structural thoracic scoliosis and pelvis symmetrical. And the final, SL-STL type, no structural thoracic scoliosis, but structural lumbar or thoracolumbar scoliosis. Yes, as I said before, we have main types of scoliosis, but each type has divided into 2 groups, plus and minus. I will be explaining the symbols plus and minus and what type of classification it is. You will see on upcoming slides, not now, but for now, we mentioned that we have 4 main types of scoliosis and each type has also divided into 2 groups. Yes, you see the diagram on your screen, and with this diagram, we can define the types of scoliosis. When we want to classify scoliosis, we need to ask 3 questions. The first question, Is there a structural thoracic curvature? The answer can be yes or no. If the answer is yes, then we move on to the second question. Where is the pelvis according to trunk? If the pelvis on thoracic concavity, we call it 3C type, as I said before. If the pelvis on thoracic convexity, we call it 4C type. If the pelvis symmetric, we call it non-3, non-4 type. Let's go back to question 1. Is there a structural thoracic curve? If the answer is no, then we move on to question 1b. Is there a structural lumbar or thoracolumbar curve? If the answer is yes, it means this is SL-STL type. Let's elaborate on this a little. How can we decide this type is whether plus or minus? We should go to question 3. Is overcorrection allowed for the main curve? If the answer is yes, it means this is plus type. If the answer is no, it means this is minus type. For example, if we have 3C type, it means, let's remember, we have thoracic structural thoracic scoliosis and pelvis on thoracic concavity. This is 3C type. But if we have 3C without lumbar or with minor lumbar, we call it 3C plus, and plus means overcorrection is allowed for the main curve. Main curve is thoracic for 3C type. What is 3C minus? 3C minus means 3C with significant lumbar. And of course, if we have significant lumbar also, overcorrection is not allowed for the main curve. Let's look at all types of scoliosis one by one with examples. This is 3C plus. This is 3C plus. 3C means we have structural thoracic scoliosis and pelvis on thoracic concavity. But if we have 3C without lumbar or with minor lumbar, we call it 3C plus. We have much more significant thoracic compared to lumbar, much more significant curvature, much more rotation in thoracic region. This is 3C plus. This is 3C minus. As you may assume, this is almost the same with the previous one. There's a structural thoracic curvature and pelvis is shifted to thoracic concavity, but the only main difference is we have structural and significant lumbar curvature. And as you may assume, we cannot overcorrect for this type of scoliosis, because if we overcorrect, it will affect lumbar curvature negatively. Minus means overcorrection is not allowed. And moving into the next type, 4C type. 4C means we have structural thoracic scoliosis and pelvis on thoracic convexity. If we have 4C, there must be have lumbar curvature, because we say structural thoracic scoliosis and pelvis on thoracic convexity. We have to lumbar curvature, structural lumbar curvature. And how can we decide plus? We move on to the third question. Is overcorrection allowed for the main curve? If we have 4C with minor thoracic, we call it 4C plus. And plus means overcorrection is allowed for the main curve. Main curve is lumbar curve for this example, for this type. And this is 4C minus, almost the same with the previous one, because this is 4C also, but now we have two structural and significant curvature. It means if we overcorrect for the main curve, for the lumbar curve, it would affect thoracic curve negatively. It means this is 4C minus. And the next type, non-3, non-4 type, let's remember what is non-3, non-4. non-3, non-4 means we have structural thoracic curvature and pelvis symmetrical. If we have non-3, non-4 without lumbar or with minor lumbar, we call it non-3, non-4 plus, and overcorrection is allowed for the main curvature. And this is non-3, non-4 minus, and this is structural thoracic scoliosis and pelvis symmetrical, almost the same, but now in this case we have two structural and significant scoliosis, significant curvatures. It means overcorrection is not allowed for the main curve. If I overcorrect, it will affect the other curvatures negatively. Finally, this is SL-STL type. In this case, there is a major difference from the others because now we have no structural thoracic scoliosis, but structural lumbar or thoracolumbar scoliosis. And this is SL-STL minus. We only come across this condition in degenerative cases. For example, adulthood or postmenopause. And finally, I would like to state that in this condition, we never perceive overcorrection as an option since it is degenerative. The only main differences, this is almost same curvature, but if we have SL-STL minus, it must be degenerative curve. Thank you for your listening and participations.
Thank you very much, Burcin, for your great presentation. I think it was very important to see this, to choose good treatment, but first diagnosis, to choose good diagnosis first for special this type of scoliosis. Thank you very much one more time, Burcin. The next speaker, next presentation will be from Silvio Selfo. Please, Silvio, if you can present us 3D principles of correction, please.
Thank you, Lukasz. But
we can try to do this.
Okay.
Please, Burcin, you can with your screen if you can. Thank you. And Silvio, please.
Welcome.
Thank you very much.
Okay, I think you see my.
Yes, it's okay now.
Okay, in our school, we have 4 3D principles of correction. We include 3D autocorrection, corrective or rotational breathing, muscle activation, and stabilization. In 3D autocorrection, we include elongation, pelvic correction, asymmetrical sagittal straightening, and frontal plane correction. In rotational breathing, it's important to expand all the collapsed area in 3D correction. And during exhalation, we have to keep the expansion in 3D correction. And after this rotational breathing, we have to activate the muscle. So in every exhalation, we have more activation. And we have some techniques for muscle activation like thoracic countertraction, shoulder countertraction, mobilization in 3D correction during exercise. After all this correction and the muscle activation, we have to stabilize all this correction, and we have to train our patient to keep this correction in activity of daily living. In our school, we have a specific clinical terminology to describe the concave or the convex parts of the curve. In the we use thoracic side to describe where is the part of the thoracic hump. We use a lumbar side for the lumbar prominence. And in the frontal view, we will see ventral rib hump with number 9, and number 10 we'll see ventral flat zone on this side. We use self-elongation. Self-elongation is a pair of forces, of opposite forces, cranial and caudal. We always use self-elongation to get the best effect of correction. Here is an example of how we use the pelvic correction. In our school, we have 5 pelvic correction. For all type of scoliosis, we have 5 pelvic correction. This is an example of how we use this pelvic correction in one curve type from our classifications. Scoliosis is a torsional phenomenon that created an inverted asymmetrical sagittal profile. That means that what is back on one side is always forward from the other side. Every block is rotated and shifted and rotated to the opposite or above below blocks. This means that asymmetrical sagittal straightening, the direction of correction is always forward and backward. Correct the sagittal and transversal plane together. Asymmetrical sagittal straightening goes always together with self-elongations. Corrective or rotational breathing. The corrective or rotational breathing, the concept of this is to expand all the collapsed area. So we have to expand weak side, weak point, ventral flat zone on T side, sometimes ventral flat zone on L side, L side shoulder in proximal thoracic scoliosis, and to train the therapist how to use their hands for the corrective breathing. In muscle activation, as I said, we have 2 techniques like thoracic countertraction and shoulder countertraction. We use thoracic countertraction to correct the weak side, and thoracic concavity. And we use shoulder countertraction to correct the shoulder block and to open the shoulder concavity. The purpose of bringing everything in 3D is to bring the patient from scoliotic posture to the corrective posture and to educate the patient for stabilization of correction during activity of daily living. In some curve types or in plus sign, we use overcorrection technique. We have overcorrection exercise to get the maximum of correction for the main curve. Be careful, we use overcorrection in some exercise and also in some curve types, not in all of them. Thank you for your attention, and this was my presentation. I hope you like it.
Yes, Silvio, thank you very much for a great presentation. We hope the exercises will develop during the PSSE-Schroth method evaluation process and treatment process, so we can try to learn about this much. Please now the third presentation in this third part. Please, Nikos Karavidas, to show us PSSE-Schroth advancements and treatments results. Please, Nikos, the floor is yours.
Thank you, Lukasz. Also, thanks to my colleagues that already presented the classification and the 3D principles of correction for our school. I will speak a little bit about advancements that we have done with PSSE-Schroth method, and also to present you some of the treatment results that we can get so far. Before starting, I would like to pay a tribute to my mentors, because these people are the main reason why I'm finally here to present my ideas. I consider myself lucky enough to be educated by some of the masters in the field, like Manuel Rigo for BSPTS Rigo concept that I used to teach for the last 5 years, Axel Hens from Schroth ISST in Germany, Dr. Hans Rudolf Weiss from Schroth Best Practice, Dr. Jean-Claude Demarbois from Lyon method, and Stefano Negrini and Michele Romano from the SIAS group. All these together, they gave me the knowledge plus my own experience to create what we can name now as PSSE-Schroth method, which is the latest development in scoliosis and kyphosis treatment. Is a program of physiotherapeutic scoliosis specific exercises based on 3D autocorrection, patient education for activities of daily living training, and stabilization of the corrected posture. So we are a program of specific exercises, both for scoliosis and kyphosis. There is a development of a new curve type classification that was described before, and some innovative ideas for 3D concept of correction. Of course, our school has received influences from my education in many different PSSE schools, but the basis is the original Schroth method. The idea behind PSSE-Schroth was to adapt concepts and techniques from other schools, keeping their advantages and improving any potential limitations, but a lot of new concepts were ascribed by my personal experience in the field. So speaking about the curve type classification, the advancements are that we have a very easy and accurate way to classify and describe every curve type, excluding no curve, by just answering 3 simple questions. This is all. You need just to, the therapist, to answer these 3 simple questions to get the whole classification. And my idea behind the classification is not just to divide the curve types into different categories. An accurate classification should give you the proper information on how to accordingly treat your patient. So it's not just to decide this is a specific curve type. You need to understand how to correct each curve type. And the concept of overcorrection, so the decision for the last question, whether to classify plus or minus, is based on clinical, radiological, and sometimes also prognostic criteria. And it's important that it's taken from the initial classification, so the therapist can understand from the very beginning on how they will approach the patient later on when they have them in front of them. The main aim for this classification is to get the maximum of correction for the curve types that is recommended and is safe to do that, and avoid creating compensation when it is risky, especially when we speak about double or balanced curves. And on the second section of this, my idea behind this classification was to avoid dilemmas that can create for the therapist. So some of them could be how to classify and treat curve types that are balanced. So in some other schools, you have to decide whether the main curve is thoracic or lumbar. For us, it doesn't matter, because this can be very tricky sometimes. You will see some examples on the next slide. Also to avoid dilemmas on how to classify and treat curve types when pelvis is almost balanced, or how to classify and treat curve types when you are not sure whether thoracic is structural or not, or to avoid dilemmas on how to treat thoracolumbar curves, which is a specific category that should be analyzed better. So first, speaking about the dilemmas about which curve is the major, thoracic or lumbar. Sometimes it's clear, but some other times it's not really clear. And some schools, they use different ways to classify according to the main curve. But for us, there are just 3 simple questions. You can get the classification and you have all the proper information on how to treat your patients. So let's say, for example, when you have minus types, 3C minus, 4C minus, non-3, non-4 minus, sometimes it can be difficult to classify for other schools. For us, it's not a problem. And even if you are in a dilemma, you will see, of course, when someone can attend our courses, how you can find the solutions to give the best exercises for your patient. Some other example could be a dilemma when you, for example, take a look on non-3, non-4 plus patient. To my eyes, this should be classified with pelvis symmetrical, so non-3, non-4. However, sometimes it's quite tricky also for the therapist to classify non-3, non-4 or 3C, or non-3, non-4 or 4C, because the pelvis might be very slightly imbalanced and you need to take a decision in front of your patient on how to classify. for us is not a big deal because we have all the proper exercises based on the curve type, so it's not really big problem. Another issue could be another dilemma for a therapist, for example, when you are in between to classify 4C plus and SL-STL plus, which means, let's say that you ask the patient for a forward bending test and you see a very minor thoracic hump and you are not sure whether to classify this as structural or non-structural. So again, we can give you the solution because even if you classify this as structural thoracic and you say 4C plus, you will still do overcorrective techniques and overcorrective exercises for the main lumbar or thoracolumbar scoliosis. Similarly to when you have, for example, a single lumbar and you consider this minor thoracic not to be structural, and you can again find the solution on how to treat your patients. And also for thoracolumbar curves that I mentioned before, please take a look on the SL-STL plus classification on this patient. I am sure that most of you, even some of the experienced therapists, if you didn't see the X-ray that the apex is T12 for this curve type, you might thought that this is thoracic scoliosis. And for those that you are familiar with Barcelona Scoliosis Physical Therapy School Rigo concept, you might be in a dilemma to classify between 3C plus or STL plus. And there is a huge difference because in 3C plus, you can overcorrect in Barcelona school, but not in group 1-2 for this school. However, for us, as you can see, is not a problem. Again, because whether you classify STL or 3C based on the apex, if it is T12 or above, you can do the overcorrective techniques and overcorrective exercises for the main curve, and this is very, very important. Regarding the educational plan, we have a proper duration for education. So in 9 days, you can start applying the method in every curve type, and 3 days of them, the basic course is online. So you can even be educated with a high quality of theoretical education for clinical and radiological measurements and scoliosis prognosis to take the best decision for your patient, even without traveling, because you can have this education online. And we also have created in our school a unique patient evaluation form, which is given to our participants. In terms of practical application, the idea behind PSSE-Schroth method can be described maybe in a few words. You should be able to treat your patient precisely and safely to get the maximum effect of exercises based on their curve type. We have created some innovative concepts of corrections. There is a new terminology with perfect accuracy on describing the body blocks and the concept of corrections. There are new ideas for corrective and rotational breathing, new techniques for muscle activation. They were described before by my colleague Silvio. New concepts also for activities of daily living training, which should be, again, curve pattern specific and is different, for example, when you have 3C plus and you have 3C minus. This is quite an advancement from our school. We have new exercises and different execution of already existing Schroth exercises based on the curve type classification, new ideas for mobilizations, and we combine a lot corrective breathing with mobilizations. And we pay special attention on proximal thoracic scoliosis and creating new concept of correction for that, and also special emphasis on thoracolumbar curves, introducing new terms like the ventral flat zone on the L side, which is the area just in front of the thoracolumbar hump, and new ideas of corrections. So I would like just to share some of the results for PSSE-Schroth method, starting with some of them with mild scoliosis below 25 degrees treated only with exercises. You can see in this patient a significant clinical and radiological improvement. Again, for this curve, we achieved to decrease this from 25 to 10 degrees. No brace was used, just exercises for this curve type. And you can also see the clinical improvement of the patient, the body balance, and also the significant correction of the vertebral rotation on the X-ray. Another example with a double curve at the end of growth. So late reserve 4, no brace for this patient, just exercises. And we got a very nice reduction of the curve with a significant clinical improvement for the patient. Another case, reserve 4, 30 degrees single thoracolumbar scoliosis, reduced from 30 to 13 degrees, clinical improvement. And again, you can see on the position of the pedicles, the improvement that we got for this axial rotation on this patient. Of course, the method can be applied in adult scoliosis, and I can say even for some severe scoliosis. Of course, we don't expect that this result is something that we see every day when we treat a patient with very severe curve of more than 70 degrees. However, sometimes you can get a very nice correction, even in these curves, if they are flexible enough. And we got 18 degrees of reduction in this curve type, and this lady was 38 years old. Again, young adults can be a category that you can expect very nice improvement of their scoliosis, because these curves are still flexible enough. You don't have degeneration, you don't have growth, so you don't have high risk of rapid progression. And if you treat them properly, you can get a very nice improvement for their curves. And I think that bringing them into better balance, as you can see, you can prevent degeneration and progression in the long term. Again, similar example, 53 degrees reduced to 46. And you can also see the correction of the vertebral rotation on the X-ray. There was a talk before by Yavuz about exercises and brace. Of course, we combine brace with exercises, and I think that the C-no type braces are really compatible with what we do, because we have the same expansion rooms in the brace with areas that we can use our hands as therapists to expand the collapsed areas for the patient. And you can see sometimes that we can get a very nice reduction of the curve. Still, the main aim is to halt progression. But if you have a good brace, you have a proper program of exercises and good compliance by the patient, you can expect to have even significant improvements like these curve types reduced too much by bracing and exercises. Also this one. And we know that we can also expect, even in more severe scoliosis at the surgical range above 40 degrees, that you can get some very nice correction, especially when you treat single scoliosis. This is one of the results coming from our clinic that hopefully it will be published very soon. And I think is great to understand also for the patients with severe scoliosis that still non-operative treatment can be successful for them. So you can see a very nice correction for the severe scoliosis. Again, this patient coming from Albania, outside of Greece, 2 years later, we got a very nice correction for her. And also for this patient with a severe scoliosis, 65 degrees reduced to 47 with a very nice clinical improvement. And I have to say that also clinical improvement is very important for the patient in terms of aesthetics, but also bringing the patient into better symmetry. It reduces the asymmetrical loading for the future, so less potential for having problems and low quality of life in the long term. Thank you so much for attending this presentation.
Thank you very much, Nikos, for your great presentation. If I can say one word, so it is the results can be very interesting for us, for people who is treating scoliosis and patient with huge problems. So in my opinion, for me, is very important how to treat adults people, and I think it's a very, very good way to use a PSSE-Schroth method, like you said. Thank you for your results. So we have a few questions, but before this, we will try to give the voice for our colleague. Please, Sarah Mohamed Ali, please tell us, what can you say about our team? Please meet our team with Sarah Mohamed Ali. Thank you.
Welcome, everyone. It's a pleasure to be here with you all. I'll just share my screen.
Great.
So I'm going to talk about the educational plan of the PSSE-Schroth method. The first part of the course is the basic, which is 3 days online course in Zoom. The online course is designed to help the participants learn the basic and theoretical knowledge of scoliosis, including etiopathogenesis, prognosis, treatment, indications for scoliosis, and kyphosis. It also covers in detail clinical and radiological evaluation of scoliosis and kyphosis. The participants learn with the help of the course instructor how to measure X-rays and practice it together. And the online course prepares you to the introduction of the 3D principles of correction, the scientific evidence for PSSE and bracing, and PSSE-Schroth classification. Level 1 course is 6 days practical course. It focuses on analysis of PSSE-Schroth classification, and the participants will be able to decide what type of exercise to perform to each patient and their ability to achieve overcorrection or not. The practical education of all scoliosis and kyphosis types will be under the supervision of the instructor. It also includes observation of treatment with real patients. Level 2 course is 6 days course. There will be more advanced exercises for kyphosis and scoliosis. This part is beneficial to participants who never dealt with scoliosis patient before. There will be an introduction to other scoliosis types like the congenital, neuromuscular, adults, degenerative, and post-operative. And also there will be another introduction to the braces for kyphosis and scoliosis. The master's course is 4 days. It's optional, and you don't have to take it to take the final certification of PSSE-Schroth. It's more for participants who want to deepen their knowledge about bracing, how to evaluate them, and how it works. It also includes more information about other PSSE schools, the surgical options for scoliosis and kyphosis, either spinal fusion and non-fusion techniques. Next, I will introduce our team, with Nikos Karavidas from Greece. He is the chair of PSSE-Schroth method. He was teacher for Barcelona School for the last 5 years, and he gave more than 40 courses worldwide. He's certified from ISST, Best Practice, PSPTS Lyon, and he's a scientific committee member of SOSRS and was active member all that time. Also, he's a faculty member of Eurospine, teaching for the EDESC program, and recently is a Scoliosis Research Society member, and he has done publications about PSSE and bracing. Next, with Yavuz Yakut, he's a professor at Hasan Kalyonsi University. He's clinical consultant at Ankara and Istanbul with 38 years of experience with huge scientific experience, more than 3,800 citations. He's a SOSRD member, and he's an orthotist and bracing specialist and certified from PSPTS and PSSE-Schroth. Lukasz from Poland, he's a PhD physiotherapist. He runs his own clinic with 17 years of experience. He's a scientific committee member of SOSRD, and he's done a lot of publications, completed various courses related to physical therapy and scoliosis, including FITS and CS. And Dariusz, he's not with us today, but he's one of our team members. He's from Poland. He's PhD physiotherapist, associate professor at university in Poland, and he has his own clinic with 24 years of clinical experience with scoliosis. He's SOSRD board member, and he has a lot of scientific publications, as well as certified from FITS, CS, PSPTS, and completed a lot of courses related to physical therapy. Merve from Turkey, she's a PhD physiotherapist and research assistant at Hasan Kalyonsi University. She has 6 years of clinical experience, a SOSRD member, and also certified from PSPTS and PSSE-Schroth. She has also done a lot of publications in scoliosis. Burcin from Turkey is a master's student at Hasan Kalyonsi University. She has her own clinic with 6 years of clinical experience. She's certified from many schools, scoliosis-specific schools like ISST, Lyon, PSPTS, CS, FITS, and done also the ESICO Master course. Georgiana from Romania. She holds a master degree at physical therapy. She has her own clinic with 7 years of clinical experience, and she's certified from ISST, CS, and PSSE-Schroth. Me, I'm Sarah from Egypt, and I hold a master's degree at orthopedic physical therapy. I'm a partner and head of 4Kids Therapy and Cojocaru Scoliosis Department, working with all types of scoliosis, including the idiopathic adults and neuromuscular patients. I have 7 years of clinical experience and certified from PSPTS, CS, ISST, Lyon, SciCheft, and PSSE-Schroth. Silvio from Albania. He's an assistant professor at Athens University. He has his own clinic with 3 years of clinical experience, and he's also certified from PSPTS, CS, and PSSE-Schroth. Finally, Larisa from Romania. She holds a master's degree of physical therapy. She works in her clinic, and she also works with the pediatrics and neuromuscular cases. She has 7 years of clinical experience, and she's certified from CS, ISST, and PSSE-Schroth. Our upcoming course will be held in Cairo, Egypt from the 9th to 14th of June, and the basic part will be from 19th to 21st of May. All participants from any countries are welcomed. The venue will be in Nasr City at Burcin Therapy Clinic. Also, there will be another course starting in Greece in July from 18th to 23rd, and the online part from 21 to 23rd of April. The official website contains all the information, and then the next days we will announce the dates of the other courses in the other countries. Thank you for your attention.
Thank you very much, Sarah. It was very nice to hear you and see all these things about our method, about our specialist, and about PSSE-Schroth method technique. So we will try to end this session, and I think we are with the plan, and we will have about 15 minutes for our discussion about all these things what we hear today. So maybe at first, at the end of this third session, we would like to ask some questions. Please give me possibility to back to our question and answer session. Maybe at the beginning, we will try to most of these questions directed to our teacher of the method, our main teacher of the method, Nikos Karavidas. So please, Nikos, I will write the first question from Mary-Louise Smith. Do you think first you need to start with teaching the stabilization, and when the patient can stabilize, then you start with mobilization? Or do you think that you always need to mobilize first and then start stabilization? Please, Nikos.
Thank you for the question, Marie. I think that, of course, mobilization can be for rigid curves from the very beginning, because to get the best effect of correction, you need to put them in balance. But in our school, there is a concept not only of mobilizing the patient independently of the treatment. We use a lot of mobilizations combined with corrective breathing. However, the main aim is first to teach the patient on how to get into the best possible 3D alignment. This is the first 3D principle of correction for us, 3D autocorrection. Of course, you need stabilization for sure. Then you go to the corrective or rotational breathing by expanding the collapsed areas, keeping the expansion while exhaling, and activating more in correction. This is the main idea. So you can use the mobilizations according to the patient that you have in front of you. But even in mobilization, you still need to keep the stabilization. Stabilization of correction is absolutely necessary.
Thank you very much, Nikos. So, and the next question is from Andrea Dragunoiu. What would you be the youngest age that PSS would be able to be applied on patients?
Yes, this answer is not only about our school. I think it's generally speaking for every PSSE school. When you treat very young patients, it is not easy to apply the full concept of 3D correction with them because you need active participation by them, and it's really difficult to explain at a very young age what is the importance of doing all these techniques. So my idea is that, of course, you can start working with very young children in our clinic. We work with children like 5-6 years old, but you have to simplify the program of exercises so that they can see it, let's say, like a game for them, or something that they can do it easier to get some part of the correction. But you cannot expect at a very young age to work similarly with a typical adolescent at the age of 11, 12, or 13. But if the prognosis is against these curve type at a young age, you can start doing exercises and you observe how the treatment process is going.
Thank you, Nikos. If I can add, I think very important is to cooperate with the patient. Is it possible cooperation with this patient, and the age it could be different to start PSSE during our, I think, experience like we have.
It is true, Lukasz. However, I have to say you that sometimes you might find better cooperation with an 8-year-old compared to 14 or 15 years old. So it's also individualized. Sometimes it depends, but the younger the age is more difficult to explain all these to the child, but you have to try.
Yes, of course. Thank you very much. The next question from Dina Chalom. It is curve classification system primarily for physiotherapists, or is it also for orthotists as they create braces? Please.
Yeah, at the moment, this is classification mainly used by physiotherapists. However, I can tell you also from my experience in the last years, because this classification is not new for me. I used to work with this way of classifying my patients, and I always had the chance in my clinic to treat a lot of patients with brace and exercises. So I can tell you that this curve type classification can be very well applied in brace treatment, and you can get again the idea on how much to correct in the brace. So when you have a patient that you can clinically classify them as plus sign, which means you can get some more correction, maximum correction for the main curve, also this concept can be applied in the brace. And of course, the opposite way, when you classify minus, it means don't use an overcorrective braces. I can tell you from my experience with many different brace designs that I have seen in my clinical practice, sometimes you have more or less balanced scoliosis and the brace is quite aggressive for one of the two curves, and what you get at the end of the day is correction of one in cost of worsening the other. And yes, when you have to classify minus, it means that it matters a lot to worsen a secondary curve.
Thank you very much. Next question is from Babak Begi. For those cases with no braces, what is the dose of PSS-Schroth exercises within 1 to 2 years of treatment, please? So there are two parts of this, but maybe the first one, if I got understood.
Yeah, so always you have to understand that it is an individualized evaluation. This is why I think it's really important to give the proper information to our therapists from basic course about scoliosis prognosis, about clinical and radiological assessment, and we have two excellent presentations in this webinar to give you an idea on that. So you have to decide according to the risk for progression. A typical recommendation could be to do the exercises like 4 to 5 times per week at home for 30 minutes to be realistic that the patient can do. What I usually prefer to say to my patients is to, let's say, give them the least that I want to have a good result. So I usually tell them, I want you to do at least 4 times. If you do more, you get more benefit. But I have to set the lower limit to get a good treatment result. But it is an individualized decision based on the risk for progression. And for the second part of this question about motivation of the patients, thank you for giving me a nice pass to explain that this is one of the most difficult parts of our job. It's not enough for the therapist to have the knowledge by themselves. You need to have the ability to transmit to the patient the motivation to do the exercises. Otherwise, if the patient is not compliant, please don't expect that you will be a good therapist having good result, because the good therapist should provide good result for the patient. And I have to tell something that I really believe, and it came from my experience, and I usually say in my courses, please don't consider yourselves as therapists as part of the success when you have a good treatment result. Please try to consider yourselves as part of the fail when the patient is not compliant and you don't have a good treatment result. You have to make your self-criticism in order to improve yourself and to think whether you could use a different strategy to motivate more your patients. So if you do that regularly, I think this is a very nice way to improve yourself and to go forward. So thank you for this question.
Thank you for the answer, Nikos. And the next interesting question is from Mary-Louise Smith. I often hear from my patient that the doctor in the hospital told them that they, when they can stop wearing the brace, that they could stop exercising also. What is your advice for how long or till what time the patient needs to do intensive exercises? Please for the answer.
I think that this part was mentioned in some way by Yavuz in his presentation about the weaning phase of the brace. So the time that the doctor said to the patient is time to stop wearing the brace by gradually reducing the brace wearing time. I think the role of the exercises is absolutely necessary at this stage, because normally having no effect from removing the brace, you can expect some drawback of scoliosis, so some worsening, and the role of the exercise is very important. What I usually say is at least 6 months after brace removal, you still need to be compliant. And then, of course, it is again individualized. It depends on the care type that you have. If you have a patient with a severe scoliosis, they must follow the exercise regularly in their later life. But if you have a mild scoliosis, maybe you can just reduce the dosage of exercises. And I think one of the key points to maintain a good treatment result in the long term is education and activities of daily living training, because you cannot expect that the patient will be compliant for the very long term in their lives, doing the exercises at a regular basis. But if they are well educated by the therapist about how to unload their spine in the daily life activities, this means that it protects them from asymmetrical loading, so from future progression, and to ensure that the quality of life can be better.
Yes, of course, I agree. And thank you for the answer for this interesting question. Next question, because we have a little much time, is from Roban to Andrea. What are the goals in Research 5 patient? Do these objectives differ according to the magnitude of the curvature? Can you try to answer?
Yeah, sure. Again, I think it depends on the curve magnitude and the risk for progression. We usually say that when the curve is below 30 degrees, there is low potential for progression in the long term. However, it's just percentage. We don't know. Sometimes you can have a patient with 20 degrees of scoliosis having progression in the long term. Some other times you can have 40 degrees with no progression in natural history. So again, it's individualized. And so it depends of the curve magnitude. And I also think that it depends on the, let's say, the general clinical appearance of the patient, because sometimes they come to the clinic at the end of growth or as young adults to receive treatment to improve aesthetics. So you have to do something for that. And this is why I mentioned that clinical improvement is very important. And some other times, of course, they come because they have pain. So pain improvement is one of the aims, especially when we treat adult scoliosis.
Yeah, thank you very much. And I think we have time for one more question. I think it could be interesting for us, for physiotherapist who is trying to help a patient with huge scoliosis. From Mio Selim, I think for Nikos, from your experience, several cases 60 degrees or over, adolescent, does exercises help even combined with brace? What is your opinion?
Yeah, I presented some of my cases. Of course, when you have a very severe scoliosis, you can also think about surgical treatment. However, my concept is that before you take a decision, which is really difficult, whether to be operated or not, at least try a proper non-operative treatment to see what you can get. My experience says that, especially when you have single scoliosis, so no double curves, you can expect to have a very nice stabilization or sometimes improvement, both in radiological and clinical terms for these curves. And I always combine exercises with brace. This is not my personal recommendation, but also from the scientific societies. It seems now, and also from the published evidence so far, that brace plus exercises is superior to brace alone.
Thank you very much. Yes, in my opinion, it's too very important to do individual for each of patient which we have, which we are diagnosis. Okay, maybe I give my voice to Professor Yavuz to if we will have some time, but there is a lot of question too. So I think we will try.
I think that maybe we can, if the participants are still here, maybe we can stay for 5 more minutes to answer at least some of them, because I think that there is some repetition in the questions. So not to leave anything without an answer. So there is a question about how effective is Schroth method. This is very general question to be answered. Of course, there are different Schroth techniques. I can tell you that Schroth exercises have, and Schroth method in general, no matter if it is called ISST or PSSE-Schroth or best practice or Barcelona school, we have quite good evidence for that. And another question is about the overcorrection. I think that it was explained. Overcorrection means maximum of correction for the main curve. And please don't think that when you classify minus, it means no correction. Even when you classify 3C minus, 4C minus, non-3, non-4 minus, you get a perfect 3D correction for the patient. But overcorrection means that this curve type allows you to get the maximum effect of correction. There is another question about proximal thoracic scoliosis. It was mentioned in our classification that we use S-type for proximal thoracic scoliosis, and we have some very innovative ideas on how to correct these patients. And I think it's very important because the braces cannot go up to that. level to correct proximal thoracic scoliosis, and this is also important. And yeah, I think all the others have answered. I hope I don't leave you. And after how many times you can see the first positive results? Again, it depends. But you regularly monitor your patients. So you take a lot of clinical measurements using specific tools like the scoliometer, the photographic methods that Lukasz presented to us, to be able to understand at every stage of the treatment if you are going well or not. So I think that this is okay, and maybe we can leave Yavuz for the last part of this webinar.
Yeah. Okay, thank you, everyone. Now we are closing webinar, and there is no any question. I think we will try to answer all questions, and hope see you in next webinar as soon as possible. Have a nice days. So thank you very much for everyone. Okay.
Okay, so thanks for participating. I can try to answer for some of you that you sent on the last minute, but I don't want to keep the panelists for a longer time, because I know it's Saturday is also the Easter of Catholic Easter, I think, tonight. So I will try to answer to all of you the questions that are not answered yet, or my colleagues. And I also have to thank you, all my panelists and my teaching team, for not only being here or for the webinar, but also being a part of PSSE-Schroth method now and in the future. And thanks to everyone.
Thank you, sir.
Thanks to you, Nikos.
Thank you, Nikos. Thanks to everyone.
Okay, so bye-bye to
everyone.
everyone.
Bye-bye.
Bye, thank you. Bye-bye.
Thank you.
Bye-bye.